Hi everyone, I'm Dr. Ng. I'm going to talk to you about eclampsia, pre-eclampsia with severe features. For hypertension in pregnancy, it will not cover in this lecture because it's a very big topic. So we will be focusing on eclampsia and pre-eclampsia with severe features. We go back to the basic principle again. So for any obstetric emergency, we are talking about resus. So as you can see, R is recognized. You need to know the definition of what is eclampsia, what is pre-eclampsia, what is severe pre-eclampsia, or what is the unclassified hypertension or chronic hypertension. Next is early assessment. You need to know the severity. You want to know is there any complication that has involved or any other organs that has been involved. S is for stabilization and resuscitation. It's the same principle again, DRS ABC. Next is urgent management. For eclampsia or pre-eclampsia with severe features, we are talking about controlled blood pressure. We want to treat or prevent seizures. And lastly is the subsequent management, specialist referral or special measures. In eclampsia or pre-eclampsia with severe features, we are talking about monitoring, especially maternal and MACSAF toxicity. And then we also need to monitor the fetus. Fluids is an important part, and the treatment of eclampsia or pre-eclampsia is actually delivery. Okay, so now we go to definition. So you need to know what is hypertension in pregnancy. So we talk about when the blood pressure is more or equals to 140/90 for at least 2 occasions, taken 15 minutes apart. And then you need to further classify it into mild, moderate, or severe. Okay, so mild is 140 to 149, systolic, then diastolic is 90/99. Moderate is 150 to 159 over the diastolic of 100 over to 100/09. The most important thing that you must remember, even after you are not doing a housemanship in ONG, is what is the severe hypertension. Okay, no matter where you go, you will see pregnant lady. Whenever a pregnant lady has this blood pressure range, you need to act very fast, which is more or equals to 160/110. Okay, so this is a severe hypertension. Why is it so important? It's because when the blood pressure is over this value, our brain will not be able to auto-regulate, then there is a chance that they have intracranial bleed or they eventually can have eclampsia seizures. Okay, so this number is very important. Okay, so what is an eclampsia? Eclampsia is basically a convulsion. Convulsion means seizure or fit that is not attributable by other cerebral condition in a patient with pre-eclampsia. But you have to remember, not all patients must have this chronic hypertension first, and then has gestational hypertension, and then has pre-eclampsia, then after that only has eclampsia. So it does not come in that sequence. It can come in any sequence that they like. They can come, the first presentation is fitting, then after that only the blood pressure go up. Okay, or they can come with an intrauterine death, then after that only eclampsia. Okay, so most of the time you can see eclampsia in the postpartum period, usually in the first 24 to 48 hours. Okay. As for this classification, it's a quite wordy slides again. Just summarize to you now. So when we talk about gestational hypertension, for your information, there is no more pregnancy-induced hypertension. The pregnancy doesn't induce the hypertension, so it's something else that causes the hypertension. So for gestational hypertension, meaning that it's a new hypertension that occurs more or equals to 20 weeks pregnancy, without significant proteinuria or other characteristic to define proteinuria. Whereas for pre-eclampsia, which is the more severe one, we call it as hypertension more than 20 weeks with significant proteinuria or other characteristic that define pre-eclampsia. We will talk about this later. It can be superimposed or it can be a new pre-eclampsia. Then we'll talk about what is superimposed also later. Chronic hypertension, meaning that the hypertension was detected before 20 weeks of pregnancy or before even the patient is pregnant. Unclassified hypertension is you didn't know actually when was the hypertension diagnosed. Okay, all right. So why is 20 weeks so important to differentiate whether this is gestational hypertension, pre-eclampsia or not? Okay, that is because the pathophysiology is back to second wave trophoblastic dilation. So what does that mean now? So you look at this slide. So when during around 16 to 20 weeks time, that's the time that your trophoblasts will invade into the maternal myometrium, and they will actually eat up the smooth muscle here, so that it can cause vasodilatation. After the vasodilatation, then you can have this low resistance flow. When you have low resistance flow to the placenta bed, your blood pressure will also come down. Okay, so this is a normal process. But in pre-eclampsia patient, this trophoblastic invasion has failed. So this trophoblast did not invade inside. So the smooth muscles over the spiral artery is still remains strong. So you will still have high resistance flow over here. And when this high resistance flow is here, so your blood pressure, maternal blood pressure will increase. So therefore you have hypertension, and also the oxidation stress, and it also causes inflammatory reaction and response here. So it secretes a lot of cytokines, and it triggers the mother to have reaction. That's why it's a systemic effect for the mother. Okay, and the blood flow to the fetus will be reduced, because you can obviously see the flow here is actually being reduced. So that's why they can have fetal growth restriction. Okay, so what is pre-eclampsia toxemia, PET? So pre-eclampsia is a hypertension, gestational hypertension associated with more or equals to one of all these things. Looks a bit wordy, but we go through it one by one. First of all, you need to know what is proteinuria. Okay, it is normal to have non-significant proteinuria because of in your glomerulus. Okay, when there is increase in GFR because of pregnancy, the protein will be filtered out first, then it has to be reuptake. So in an abnormal situation, there's too much of protein being secreted, then cannot be reuptake. That's why you have proteinuria. So you need to define what is a significant proteinuria means. So significant proteinuria means when you do a 24-hour urine protein, you collect it, and then it is more than 300 milligrams per day. And you need to know how to collect 24-hour urine protein. So when the patient wake up in the morning, so the first urine that she pass out is actually collected from the day before, right? So you need to discard that one. And then after that, only you start to collect all the urine until the next morning after she pee the first time. Okay, so that is how you collect a 24-hour urine protein, and it has to be more or equals to 300 milligrams per day to say that it is significant proteinuria. Meaning that if, let's say, the 24-hour urine come back as 30 milligrams per day only, then it is actually not significant, so we are not that worried about. Okay, next is it is very difficult for everybody to bring back a tong to collect the urine for 24 hours, right? Sometimes I ask you to drink water, so you will forget. So what we can do is we can do a spot test, which is a urine protein creatinine ratio, what we call it as urine PCR. So it's actually a ratio counting protein to the creatinine. So if it is more than 30 milligrams per millimole, then it is considered as significant. Okay, then if let's say you have a patient with gestational hypertension plus a urine PCR of 40, then you can say, okay, this patient has pre-eclampsia toxemia. Okay, when you do a urine dipstick, if it is more or equals to 1+, you will need to do a PCR to see whether this is actually more than 30 milligram or less than 30 milligram. Okay, all right. So next, what is maternal organ dysfunction? So you can see we have kidney, liver, neurological, and hematological. All right. So for kidney, when we talk about the urine creatinine is more than serum creatinine is more than 90, or when you have a liver involvement, when your AST/ALT is more than 40, or you have your right upper quadrant or epigastric pain lah. Okay, subsequently, what are the neurological complications, such as if they have headache, they have eclampsia, they have altered mental status, they have blurring of vision, or they have stroke. All right, so these are all considered under neurological complications. And if let's say you have a hematological complications such as low platelet, or patient has the IVC, or patient has hemolysis. How do you know whether the patient has hemolysis? You check the LDH. Okay, when the LDH is increased, then it is a sign of hemolysis. All right, and you do a PBF, you also can see whether there is hemolysis or not. Okay, So this is considered, alright, let's say you have a patient with hypertension and a urine serum creatinine of 100 at 38 weeks. Then you can consider the patient has a pre-eclampsia toxemia. Okay, so next criteria is uteroplacenta dysfunction, meaning that if let's say the patient has hypertension plus fetal growth restriction, then also you can say it as a pre-eclampsia toxemia. Okay, so the other complications that not mentioned in this criteria is features such as pulmonary edema, placenta abruptio, or patient has oliguria, which is under the kidney function. Alright. Then what is a pre-eclampsia with severe features? We do not routinely classify it into mild, moderate, severe anymore, because even a mild pre-eclampsia, eventually they can progress into eclampsia. So you cannot, it will not follow mild, become moderate, become severe, then only it become eclampsia. Okay, but if you recognize these severe features, okay, so you need to act very fast. You need to find your superior, your MO, very fast, and you need to act very fast for this patient. You need to proceed to quick assessment. You need to proceed to the next step, stabilization and urgent management. Okay, so what are the features that we consider as severe features? First of all, you look at the blood pressure. If the blood pressure is more than 160 over 110, again the same number that I have mentioned to you, then you have to alert everyone in the labor ward and you need to call your MO urgently, okay, because this is a severe features. So other features such as your IE symptoms, okay, or patient fitted, or if they have CNS signs that you can elicit, or if they have shortness of breath, or if you when you review the results, the renal function is abnormal, or when you see there is a component of HELLP, and also if let's say a patient has the IBC, or you can see abnormal CTG or intrauterine death, or even a placenta abruptio. So these are severe features for pre-eclampsia. Okay. And what is actually a HELLP syndrome? HELLP syndrome is hemolysis. Okay, so hemolysis, you check with your LDH, and then whether there is actually elevated liver enzyme, you look at the AST or ALT. So mind you, the level should be more or equals to 40 should alert you already. And also whether there is any low platelet. So platelet, if let's say less than 150,000, then we will consider it as abnormal. You no need to memorize this table. Okay, just need to remember what are the HELLP syndrome component, and the management will be similar to other pre-eclampsia with severe features. Okay, so let me just summarize this to you. Again, timeline is very important. What are the landmark in pregnancy for hypertension? It is not difficult. So from you are not pregnant, then we are 20 weeks. The reason for 20 weeks I have told you earlier. And the treatment for pre-eclampsia or eclampsia is actually delivery, and 6 weeks post-delivery is when they have passed the puerperium. Okay, so you have this Madam A who has her booking done roughly around 8 weeks. BP is normal. Then subsequently, at around 24 weeks, you noted that her blood pressure is 140/90, urine protein is negative, other parameters are normal. So the diagnosis is gestational hypertension. It is not a PIH, okay? So it's a gestational hypertension. Okay. So subsequently, at roughly around 32 weeks, she has BP is 150/90. She has proteinuria, and then also other parameters are normal. 3+ we can already say is a significant proteinuria. So this is a pre-eclampsia, but she has no other severe features. Okay. Then when she is around 37 weeks, she has hypertensive crisis. Her BP is 160 over 110. Urine protein is 3+. Creatinine is 100. So there are features of severe features of pre-eclampsia. So we call it as pre-eclampsia with severe features. Okay. So when we have Madam B here, again you look at at booking, blood pressure is normal. Even near term is also normal. Okay. Everything is normal. Then suddenly, immediately after delivery, she fitted. So we call it as eclampsia, and you can see subsequently only the blood pressure be increased. They can present it in this way. Okay. Next, another example, you have Madam C. So let's say at booking around 10 weeks, her blood pressure is 140/80, 150/80, 140/90. Then that is the time that you say that this patient has chronic hypertension. Okay, then subsequently at 22 weeks, still the same. Urine protein is negative, other parameters are normal. So she is still classified as chronic hypertension. But at 32 weeks again, so this time onwards, she has urine protein 3+, but other parameters are normal. So this is what we call pre-eclampsia superimposed on chronic hypertension, meaning that she already has underlying chronic hypertension, pre-eclampsia has set in. Okay, so but this is without severe features. Then the same thing, she has hypertensive crisis and also have some renal impairment. So this is pre-eclampsia with severe features. So again, pre-eclampsia superimposed on chronic hypertension with severe features. Okay, so how about this Madam D? So she's unbooked, unscreened lah. So when the first time you saw her, she's at 28 weeks. During her booking, BP is 150/80, and then subsequent is 140/90. So we didn't know what happened in front here. We didn't know the blood pressure, whether it was elevated after 20 weeks or before 20 weeks or before pregnancy. So the diagnosis is called as unclassified hypertension. Okay. All right. So next, this will be a little bit tricky, whereby, okay, the patient has already been hypertensive before pregnancy, okay, and she already has urine protein 3+ even before pregnancy. Okay. So some of you may say that this is actually a preeclampsia because hypertension plus proteinuria, right? But it is actually a chronic hypertension with underlying CKD. Okay. But if let's say after 20 weeks, so then you will be having difficulties to monitor whether this patient really is just having a chronic hypertension with underlying CKD, or there is superimposed preeclampsia on top of that. So that will be difficult for you to answer. Never mind, it is okay, not your level. So you need to classify properly what is chronic hypertension, what is gestational hypertension, what is preeclampsia, and what is preeclampsia with severe features. After you have recognized what kind of hypertension that this patient has, then you need to do a quick assessment. You need to know the severity. You want to know, is there any complication or any organs involved. So the same for mother, you want to know there is severe features or not. Huh? So basically, you want to know there is severe hypertension or not. You want to know the patient has any end organ damage. All right, and the baby, you want to know whether baby has fetal growth restriction or not, or IUD. Okay, the assessment that you do is basically from your history, physical examination, investigation. Okay, history, you are looking into IE symptoms. So your IE symptoms, impending eclampsia symptoms such as headache, blurring of vision, epigastric pain, okay, shortness of breath, the PV bleeding, painful PV bleeding can be suggestive of abruption, and you can also ask about the fetal movement. So for your examination, you need to check from the hair to the toe. Blood pressure is very important. Then the general examination, you need to auscultate the lungs. You need to look at the whether she's tachycardic or not. And you also need to examine the abdomen, whether there is any signs to suggest that this is an abruption, or whether the uterus is smaller than that to say that this is a fetal growth restriction. Okay, all right. For investigation, this is you are familiar with it, your PE profile, which will include your FBC. Particularly, you want to look into the platelet. Buccal is your renal function, and as well as your uric acid. And liver function, you want to look at the AST/ALT. Coagulation profile is for coagulopathy, and GSH if the patient is for delivery and according to the department protocol. And when you do a urine, you want to do a urine dipstick, then you see whether it is 1+, 2+, 3+, or 4+. So if it is negative, then no need to send for your 24-hour urine protein or your urine PCR. But if it is 1+ or 2+ and above, then you need to do. And mind you, again, it's actually a urine protein. Don't send 24-hour urine creatinine, that is for something else. It is actually 24-hour urine protein. So after you have assessed the patient, you have know whether this patient is actually a preeclampsia with or without severe features, or the patient is actually fitting. So you need to stabilize and resuscitate the patient. So it go back to DRS ABC. So DRS ABC, danger, if let's say the patient is fitting, you need to be with the patient. You need to ensure the patient didn't fall down from the bed or the chair to the floor, or you want to see is there any dangerous thing around the patient, you need to remove it. And again, this is a COVID pandemic. You need to wear your PPE before you go in. appropriate PPE. And then respond, you can go to the maternal resus tutorials to see how we assess that. And the next thing is shout for help. So what kind of situation you need to shout for help? So if let's say a patient has eclampsia, then it is actually a red alert. So when you shout for help, you can say you can shout that the patient is fitting, activate the red alert. Okay, activation of red alert, you need to check in the labor ward. Just next to the phone, there is a code that you need to call, and then the operator will activate the necessary team to come and help you. Okay, so then next is you have to open up the airway and assess the breathing and also the circulation. So for a patient who is fitting, open up the airway. You do not put your finger inside there to open it up like how the movie always show. So basically you just want to clear out anything that is obvious that is obstructing the airway. Or if let's say the patient has secretion, you can use the suction to suck it. Okay, then you provide the patient with oxygen. You can give them high flow oxygen first, and circulation is to set line now. And if let's say the patient has aborted, the feed has aborted, then you can put the patient in a left lateral position. Okay, so first you call for help. After you have ensured the patient is out of danger and you have see whether the patient is responsive or not, then you also have to activate red alert. Ictal phase, meaning that when the patient is fitting, you have to be with the patient. Okay, you can put the patient in the left lateral position and give oxygen. But after the fitting, most of the time they will be drowsy. So you need to assess whether they are responsive or not responsive. So how do you assess responsiveness or not? AVPU. Okay, alert to where they are alert, they respond to voice, or they respond to pain or unresponsive, or you can use the GCS score. Okay, if there is no response, then you proceed with your ABC. You need to open and protect the airway, give oxygen and circulation, and whether you need to intubate the patient or not. Okay, if let's say the patient is responsive, then you put the patient in recovery position and you also give oxygen. Okay, so how are you going to stop the fitting? Is basically magnesium sulfate. Alright, so for another emergency is pulmonary edema, where the patient will have SOB. Okay, shortness of breath. Then again, it's the same principle, DRS ABC. On top of that, you can give IV furosemide. Alright, at rupture, you have to refer to the obstetric hemorrhage Bruner protocol. Okay, next is how are you going to manage the next when patient has fitting, or if patient has severe features of pre-eclampsia. Your aim is to control the blood pressure, and you want to treat or prevent the seizures. Okay, it's not very difficult. How are you going to control the blood pressure? Your aim is to bring down to non-severe range. Okay, meaning that you want to bring down to less than 160 over 110. Okay, so if you need to transfer the patient, then that is the range. Okay, ideally you want to bring it down to here. So this is the target range. Many people will say that, oh, the first line is nifedipine. Actually, nifedipine, labetalol, there is not much difference in terms of efficacy. So, but in acute setting, if let's say you didn't have intravenous access, you cannot set line. Patient is fitting, how to set line. Okay, or you have a patient who come in with pre-eclampsia with severe features, very edematous, cannot find the line. Blood pressure is 200 over 110. Then you can give them oral nifedipine. Okay, so oral nifedipine, you can give a 10 milligram stat. Then subsequently you can repeat. You can see at 30 minutes you are expecting the blood pressure to go down within 30 minutes. If still not going down, then you can give the second dose of nifedipine. Okay, and whereas for IV labetalol, the first dose is 25 milligram. Then subsequently you can give 50 and 50. Okay, as for hydralazine, the first dose bolus is 5 milligram. Okay, you have to familiarize yourself with IV labetalol and IV hydralazine. Like it or don't like it, you have to. Okay, so these are the drugs you will see this table in labor ward, and I don't think the maternity ward has this. So what you can do is you can take a picture and put it in your phone, so in emergency time then you can refer back always. Okay, and if let's say you have been transferred to the district hospital or any district hospital, make sure your hospital has this chart so that it will ease you when you need to prepare the medication. Okay, when we talk about bolus, Okay, you need to know 1 bottle of labetalol has 5 ml, which is equals to 25 milligram. Okay, whereas hydralazine is a small bottle, 1 ml already has 20 milligram. Okay, so we go to labetalol first. You need to know that labetalol is, you need to use pure. No need to put, no need to add normal saline at all. Just use pure. Alright, whereas hydralazine you need to dilute because a small 1 ml is already equals to 20 milligram. So 1 cc of your hydralazine you add with 19 to make it up 20. So it will be easier for you. 1 ml is 1 milligram later on. Okay, so for bolus you give this 1 bottle of labetalol bolus over 2 minutes. Whereas for hydralazine, you have to be very careful. You must dilute it to make it become 20 cc first. Then only you give them 5 ml, which is equals to 5 milligram over 2 minutes. Okay. Please make sure you know how to dilute IV labetalol and IV hydralazine. Okay. Next, this is the infusion dose. Okay. Infusion dose meaning that you are not giving boluses. Okay. You are giving over hours. Okay. Again, the dilution for labetalol is 5 ml, 1 ampule is 5 ml, which is 25 milligram, whereas hydralazine is 1 ml equals to 20 milligram. Okay, so again, labetalol you no need to dilute, you just break 10 vials and put it into the, you just use a 50 cc syringe and syringe out whatever that you have in 10 vials. Okay, then after that, for hydralazine, you will need to use 2 ampules and then put it in the 38 ml. So it's actually the same like if you use 1 vial, then you put it into a 20 cc syringe law. But if let's say you use 2 vial, then you put it in and make it up 40 cc. So that 1 milligram is equals to 1 ml. Okay, so for labetalol, you need to know the starting dose. Starting dose is 4 ml per hour, which is 20 milligram per hour. Every half an hour, you can increase or reduce. And you need to know what is the maximum dose. Maximum dose is only 32 ml per hour. Okay, whereas for hydralazine, you can start with 1 ml per hour. Then subsequently, your maximum is 10 ml per hour. Again, your target aim is become the non-severe, but ideally we want it to 140, 150 over 90 to 109, which means it is not in the severe form. Okay. And next, what are the indications for magnesium sulfate? So first, if the patient is fitting because of eclampsia, you want to give magnesium sulfate. Second, if the patient has pre-eclampsia with severe features. Okay, so the third is when the patient is baby is less than 32 weeks, you want to give for neuroprotection. We're not going to talk much about this now. Okay, you must know how to prepare magnesium sulfate. Okay, 1 ampule, 1 vial is 2.47 gram, which is 5 ml. Okay, for your loading dose, IV, intravenous, is 8 ml of your magnesium sulfate plus 12 ml normal saline. Then you give it over 20 minutes. So in 20 ml, then you give it 15 to 20 minutes. Make your life easier. 1 ml, 1 minute. But if let's say after the loading dose, you need to continue with the maintenance dose. Please remember this now, we are using the syringe pump instead of infusion. So the syringe pump is, you use a 50 cc syringe, you syringe out 2 bottles of magnesium sulfate and then you plus 40 cc, make it up full to 50 cc, then you run it at 10 ml per hour. Okay, if the patient fit again, you can give another 2 to 4 gram of Maxaf. So how about if the patient doesn't have line, patient is fitting, then you are struggling to find lines, then the patient is still moving, having the tonic-clonic seizures, how to set line? You can give intramuscular magnesium sulfate. So loading dose is 10 gram in total. So this is very wordy, right? So how are you going to give the intramuscular Maxaf? The buttock, you divide into 4 regions. You only give the intramuscular drugs at the upper outer quadrant, okay? Because here you have the sciatic nerve and here you have the gluteal artery. You don't want to cause a hematoma, so upper outer quadrant, okay? For loading dose, you give left side buttock 2 bottles, right side buttock 2 bottles, okay? So it's together. Loading is both sides, 2 bottles each, okay? Which is 5 gram, 5 gram, 5 gram on the right, 5 gram on the left. Okay. Then after that, 4 hours later, actually, let's say for example, you are in Kapit, you want to send the patient down to Cebu, it will take you 9 hours to reach there when you go by road. So after you have jabbed the loading dose, 4 hours later, you need to jab the maintenance dose. So maintenance dose is just 2 bottles on one side, which is 5 gram. For another 4 hours later, you jab uh, another buttock lah, okay? Alright. So next is, after you have given the MAXAF, the subsequent management will be how are you going to monitor, when are you going to deliver, and the most important thing is fluids management. Okay. So for fluids, it is very important in patients with pre-eclampsia. Why it is? Because there is capillary leakage. Okay, the vessels already is porous, so it's botched already. The water in the vessels is actually leaking into the interstitial space. Okay, so that's why they can have pleural effusion or pulmonary edema. That's why they have leg edema. Sometimes when you assist the seizure, you will see a lot of ascitic fluids. Okay, and when the fluids, the water that's supposed to be in the vessels has been leaked out to the tertiary third space, so whatever inside the vessels has been reduced. So there is an intravascular fluids depletion. That's why sometimes they can have renal impairment. And they can have oliguria, they have reduced urine output. So not all patients with reduced urine output will have received a bolus, because if you give fluids resuscitation, you actually you can improve the kidney, you can improve the urine output, but you can also worsen the pulmonary edema, okay, which will cause patient to be SOB lah, then the patient cannot breathe after that. Okay, so for fluids, we give 80 cc per hour. All right, in total of all the fluids infusion and all, we give maintenance as a 80 cc per hour. Then the patient need to be monitored in high dependency unit HDU. For the mother, you need to monitor the blood pressure because you want to control blood pressure. Again, eclampsia, pre-eclampsia, very simple. You control blood pressure, you prevent the fit or you treat the fit, and you deliver the baby. Then you will treat the pre-eclampsia or eclampsia already. So it is actually not so difficult lah. So you need to monitor the blood pressure, and then when you start the patient on MAXAF, you need to watch out MAXAF toxicity. IO charting, again, you need to remember about the fluids, and you want to know ongoing, does the patient develop complications along the way, because the pre-eclampsia does not stop there and then. Even though you have delivered the patient, sometimes the effect will still last for a few days. Okay, next is you need to monitor the fetus as well, so namely your CTG, Doppler, ultrasound and all, and for delivery. So when you monitor for magnesium sulfate toxicity, you need to know why you want to monitor all these things. If you didn't understand, then you will be monitoring blindly without knowing what you need to do. Okay, so for blood pressure, you need to monitor every 15 minutes, pulse rate as well. Okay, blood pressure is because you need to control the blood pressure. You don't want the patient to have hypertensive crisis. You don't want her to have a stroke. You don't want her to have intracranial bleed. It's nothing much to do with the magnesium sulfate lah. But for pulse rate and respiratory rate, this is very important to tell you whether this is because of the magnesium sulfate overdose or not. Okay, and as well as the deep tendon reflex. So the first thing that will go off is actually the knee reflex. When you reach 4 mg per deciliter, the tendon reflex will go off. Subsequently, they will have cardiorespiratory arrest. Okay, I'll talk to you about this in a while. Why do you need to monitor the urine output? I think everybody can answer, because magnesium sulfate is excreted by the kidney. So if you have renal impairment or if your urine output is reduced, so automatically you know that the magnesium sulfate has been not excreted properly. Okay, so you might need to cut down the magnesium sulfate, or you might need to take a serum magnesium to see what happened. So when the patient has magnesium sulfate toxicity, you have to remember they get depression now, like cardiorespiratory depression. So The ideal therapeutic aim is 1.75 to 3.5. Okay, anything more than this is dangerous. Okay, because you can cause the patient to not breathing, where your respiratory rate will reduce, or you can cause the heart to stop or arrhythmia, which means the ECG changes are like PR, prolonged PR, okay, or widened QRS. Okay, so that is why you need to monitor the heart rate and the respiratory rate for the MAC-SAF toxicity. Okay, and if let's say you have a patient that you suspect or you confirm a MAC-SAF toxicity, the antidote means you can reverse this condition with calcium gluconate, 10%, 10 cc over 10 minutes. Okay, I think it is almost in the end already. When to deliver? For your level, you just need to know roughly a few timeline lah, huh? 37 weeks, if the patient has pre-eclampsia, you deliver lah, huh? There's nothing much that we are worried about already. Okay, 34 to 36 plus 6 means 34 to 37 lah, huh? So if there is fetal or maternal compromise, you deliver after you discuss with the specialist or having a specialist input, and then the antenatal corticosteroids. All right. If let's say it is less than 34 weeks, then you will need to balance in between the risk of maternal complications and the fetal prematurity. So for your level, it is fine as long as you can answer when do you want to deliver, when there is maternal or fetal compromise. All right, then you want to deliver, or when the patient is 37 weeks already, you want to deliver. Okay, so when we say maternal fetal compromise means what? So if let's say the mother 32 weeks already fitting, so of course there's maternal compromise, then we should deliver regardless of how many weeks is the baby lah, huh? So that is what I mean. So this is the summary. You go back to the resus, you need to recognize what are the definition. You need to do early assessment. You want to know, is this pre-eclampsia with severe features or no severe features? Any organ has been involved? Is this HELLP or not HELLP? Do you need help? And then you need to stabilize and resuscitate the patient. DRS ABC again. So after you have DRS ABC, the next thing is you want to control the blood pressure. You want to treat or prevent the seizure. Okay. Then subsequently, it depends on whether the patient deliver already or not. The treatment is actually delivery. You also want to monitor the mother because you start on MAC-SAF. You also want to monitor ongoingly whether the pre-eclampsia has get worse or get better. So you need to monitor the mother condition, and you need to also monitor the baby. At the same time, you have to be very careful with the fluids. So for eclampsia and pre-eclampsia, basically it's not that difficult lah, huh? So basically it's here. You control the blood pressure. Okay. So the important thing is you want to control blood pressure. You want to treat or prevent the fitting. Okay, you want to monitor mother and baby, especially MAC-SAF toxicity. You want to control the fluids, how much you want to give or how much you want to give out, and then you deliver the patient. That's it. It's not very difficult. All right, thank you.